It's about kind of fine-tuning and an opportunity for you to kind of ask me any questions, disagree with stuff, but I based it around questions. So what I thought we'd do is, if you, on the hand I've just given you, there'll be just questions, we'll go through them, and as we'll make it a kind of almost like a mock psychiatry exam, and then we will go through the answers, and you can each sort of tell me what you've put in there. Does that sound all right?
Yeah.
And it's just a slightly different way of doing it, maybe kind of wake things up a bit. So that's just a quick plug for the Royal Medical Benevolent Fund, which is for doctors, medical students who kind of hit on tough times or got substance misuse problems, debt problems, and that's a charity that helps sort of doctors and students in need. So I've told you what the aim of the session is, which is, so make a note of your answers as we go along, we'll go through them, and we'll take it in turns to sort of see what you've put for each question. So this is question number 1 then, and I'll just read it as we go so you've got time to read it. So 75-year-old man, sort of significant recent life event, he's got a history of Parkinson's disease, and he presents to his GP with some sort of non-specific symptoms. He's having difficulty sleeping because he's in a bit of pain, not eating so well, and he's lost some weight, also feeling lethargic. You know, wakes up in the morning not feeling refreshed, but he's still able to function generally. He is, you know, looking after himself. He's doing the cooking, he's doing a bit of socialising, probably not enjoying it as much as he usually does, and he's quite tearful during the session with the GP. So have a look at those diagnoses and pick the one that you think is the most likely. So is it A, bereavement, B, severe depression with psychosis, C, mild depressive episodes, D, chronic fatigue, or E, Alzheimer's. So make a note of what you think of that. Second question, this is a quickie. Which one of these does NICE say is not an appropriate management strategy for the man in question 1? So, sertraline, sleep hygiene advice, CBT-based guided self-help, group exercise, or active monitoring. Which one of those does NICE say isn't an appropriate sort of management strategy for that man from question 1? Question 3, which of the following symptoms is not a symptom of depression? So note that it's not a symptom. Is it increased appetite, psychomotor agitation, psychomotor retardation, anxiety, or increased sleep? Which one of those is not a symptom of depression? And this is another vignette then. So 66-year-old woman who is referred by GP to psychiatrist, complaining of low mood and lack of energy for the past 6 months. She's finding that she can't sort of concentrate on the normal TV programs that she watches. And she's also got problems with her appetite, has lost a stone in weight. And she's developed this belief that her kidneys are not working properly. She's not peeing enough, and she's really preoccupied by that. She's also socially withdrawn, and she's also stopped doing a lot of the things that she would normally be doing around the house. And you also discover that she's got a previous history of postpartum psychosis about 30 years previously, but otherwise has been fine. But what would your management be there? If you were the psychiatrist, what would your management strategy be? So would it be A, combining citalopram and referring for CBT, a referral for interpersonal therapy, combination of sertraline and aripiprazole, starting a atenolol, or referring for a group exercise program? And which one of the shorter question, which one of these is not recommended by NICE for treatment-resistant depression? So treatment-resistant depression, you'll know we're getting into the realms of combinations, augmentation, that kind of thing. So which one isn't recommended? Is it SSRI plus mirtazapine in combination, lithium augmentation, so adding that into an existing antidepressant effectively, quetiapine augmentation of antidepressant, sodium valproate augmentation, or venlafaxine combined with CBT, if you can access CBT. Question 6. A 78-year-old man who's been previously well. His wife died 3 months ago, so a significant life event. For the last month he's been feeling low in mood. And also, it's probably longer than that actually. A month is not quite long enough. It's exactly based on the real case. So say 3-month history of low mood, and then more recently he's developed strong feelings of guilt about his wife's death, feeling responsible in some way. He's got early morning awakening, which is what that stands for. He's profound lack of energy, really not doing much, weight loss. And he develops the belief that his wife was actually still alive when she was cremated and that he should have saved her. And he's really psychomotor retarded, slowed up, and gets to the point where he's been admitted to hospital, and he's now no longer adequately taking in food and fluids, and he's becoming dehydrated. If you were the psychiatrist there, what would your management plan be? Would you start the thiopin or tosulapin, as it's probably more appropriately known now? Would you start sertraline and refer him for CBT? Would you refer him to the ECT specialist? Would you arrange bereavement counselling, or would you start him on venlafaxine? So make a note of that. And 3 more to go. So an 80-year-old woman, not really enjoying life so much the past 6 weeks, lacking in energy. She's also got early morning waking. She's had some relationship difficulties with her husband recently, but she's otherwise well and is functioning okay. But she does have a past history of depression, where she was tried to commit suicide and was hospitalised for several months, but eventually responded to treatment with an SSRI. So, in that situation, if you were the GP and she was consulting you, what would be the most appropriate management? There may, some of these options may have merit, but what one would you choose? Would you go for active monitoring, referring to relate for relationship counselling, refer for individual CBT, start sertraline or start amitriptyline? This is a lady with quite a significant history of depression, 5 episodes of quite severe depression, has had CBT in the past. Everybody knows what CBT is. But she's relapsed in the past, even when she's been on maintenance treatment for antidepressants, has had CBT. But she is currently on venlafaxine and mirtazapine, and is well, is actually currently well on that combination. For her, what might be helpful if you were going to do one of these things and you're trying to think, well, how do we, given that she's relapsed before, even on medication, what would reduce the risk of relapse? Is it psychodynamic psychotherapy, interpersonal therapy, CBT, mindfulness-based CBT, or augmenting with lithium? And this is a 75-year-old man with moderate depressive symptoms. You're convinced of that, and as his GP, he's on that combination of medication, but he doesn't have a past history of depression. He's sort of saying, yeah, I would like to start an antidepressant. You think it's indicated. What would be the most appropriate antidepressant for him? Mirtazapine, sertraline, amitriptyline, escitalopram, or duloxetine. And this is the last one. 68-year-old woman who has got a significant past history of depression and self-harm, presents to GP, again with significant depressive symptoms, and she actually says that she's suicidal, and she, on sort of direct questioning from the GP, admits that she does have a plan, had been planning on taking an overdose and storing up medication. In that situation, as the GP, what would you do there? Start sertraline, refer for CBT, start diazepam and mirtazapine, or start venlafaxine, refer for interpersonal therapy, or refer to mental health services for older people. Okay, that's the end of the exam. How did you find that? Tough. Okay. Well, we'll go through it, and at any time, feel free to interrupt, ask questions as we go along. How are we doing for time? Is that like 10 minutes? Or?
15 minutes.
Oh, right, okay. So hopefully we'll have time to go through most of them. So for the first vignette then, won't go through it again. So we'll start with you. What did you go for?
So I thought it was probably a bereavement reaction.
Okay. Anyone have any other answers to that?
I couldn't tell at the time whether the relationship between a mild depressive episode and a bereavement reaction. I wasn't sure when
Yeah.
I just knew it again. So I put mild depressive, but only
Yeah. Yeah, okay. Anyone have anything other than mild depression or bereavement reaction? No? Okay, well I put mild depressive episode there because the reason I put that there is although it is the, it's clearly the, well, it may well be the bereavement that's triggered that. You don't know that for certain. And there is, there's significant evidence, I think, of depressive symptomatology there. But certainly it's only a mild depression. And if you did decide, well, this man needs, he does need some help. You've got a few options there in terms of how you might want to treat him. You may have your own ideas of how you might want to treat him. Can I ask you, sir, what you put as your answer to that question? What does NICE say you shouldn't do for him of those choices? If you're thinking it's a mild depression. Sorry? You went for surgery? Yeah, anyone else put anything other than... So you all said surgery, yeah, okay. So you'd be right if you said surgery. Because all the other things are recommended in terms of it's on your other hand out with a kind of stepwise approach. This is kind of step one stuff. What were you going to say?
I was going to carry on. I was just going to ask a question about the previous.
All right, okay. As a general rule, the low-level psychological interventions you'll see are all sort of CBT based. That's where the evidence base is still very much for CBT based interventions. But there are a range of things that NICE say you should consider. Whether they're available to you as a GP is a different matter.
Well, that's the difficulty I have that yes, I know we're not supposed to use this for medications for mild depression, but realistically I cannot get CBT or any of these other things for about a year and a half. So my choice is between doing nothing or doing SSRIs. So I give SSRIs.
Yeah. The interesting thing though is that the evidence base for whether they actually work for mild is just not there. They don't work for mild depression. Yeah, well, yeah. So that's a kind of it's a kind of ethical quandary, I guess, isn't it?
Yeah.
And we know that you guys are the people that are treating 90% of the people with emotional disorders. So
it's just hard to give them nothing.
Yeah. So I guess the question is about what NICE say, not what you would do. And they're guidelines, aren't they? In individual situations where you've got a patient saying, well, do you know what? I've heard that it really helped my friend actually, and could I try some of that surgery and stuff? There were a couple of questions there. Do you want to? I think you were first.
If yours is about this one, you go for it. If it's about what you...
I just wondered whether a group exercise program wouldn't have helped somebody that age instead of settling,
Yeah, but you're saying it would have done or not?
I think it might have helped.
Yeah, I think we're saying that NICE would agree with you, but NICE is saying you shouldn't go straight for sertraline. So it's not an appropriate management strategy.
Okay.
Yeah? What was your question?
It was just relating to how you sort of distinguish between, because I put bereavement reaction as well, but I was thinking too about the time.
Yeah.
Is there, because I remember there being something about time, is there